Assessing children is actually a challenging job for mental health professionals. There are various reasons why this is becoming a challenging job. The first and foremost thing is the child and adolescent in question would not have initiated the consultation or may not be in agreement with the need for a consultation. If in the case of an adult, we know that they recognize that they have a problem, or they somehow agree to their family members or caretakers or friends suggestions that it is better for you if you can go for a consultation with a mental health professional. But with children, especially children below the age of 10 years, it is very, very difficult that the child is in a position where his opinions or her opinions are never asked. Though the child is the one who's having a difficulty, his opinion is not considered at any point of consultation. It is mostly the parents who decide that the child is in need of treatment or evaluation. So this usually happens without the consent of the child. And in our OP settings, we do see children who are brought, the children are brought by telling them.
Just to briefly interrupt you, I think the slides are not visible on the screen.
It's not visible?
Yes, ma'am. We are able to see your window, but not the slides.
Okay, you can see the slides changing also?
Yes, we can see the slides changing now.
Okay, fine.
Sure, thank you.
Okay, so I was telling that the children in our settings are brought. The parents are telling them that, okay, we will go for a trip to the beach, because Calicut is known for the beauty of its beaches. So people take their children in the disguise that they are going to have nice time in the beach. But the child realizes only after entering to the institute compound that the child is brought for a consultation. And most of the institute of or centers of excellence will have their names with some indication that it is related to mental health. So in our institute, it happens like Institute of Mental Health and Neurosciences. And these children usually perceive it in parts. Like they will be reading that Institute of Mental Health is a different thing for them. So the first sentence they will say to the therapist is, I'm not mental. These people have brought me to a mental institute and I actually don't need help or consultation here. So this is a situation which is very difficult for a therapist to build the trust with the child or to begin a conversation with the child. So we actually suggest that the parents should inform their children that they are going to be in consultation with a mental health professional. They can brief them that we are, as parents, we are worried about your certain behaviors or certain kind of difficulties, and we don't know how to handle such situations. So we need help. That is why you people are taken to the consultant. So that makes things much more easier. And the second thing, second difficulty while assessing children or doing a detailed evaluation with children is the consultation may or may not be even sought for the most impairing problem at hand. The child will have certain concerns, or the family will have certain concerns and certain complaints. Most of the concerns are the things which are there in the child for many years. Complaints are the things which have come to the forefront for the last few weeks or months. So what happens is the consultation parents are taking will be for their concerns and not for the actual troubles which the child is facing at present. Then as you may be able to imagine, most of the children, especially those who are below the age of 10 years, have a phobic reaction to hospital settings. We can't blame them because they have been taken to hospitals only while they need an injection or when they are not well, where they are medicated and where they are confined, advised to confine to a unfamiliar place. So visits to hospitals are never happy moment for children. So this makes things much more difficult for the clinician. And children may not have sufficient language or vocabulary to express their difficulties compared to adults. When you see a child and when you ask them, what can I do for you? It's very difficult for most of the children to verbalize what worries they have or what difficulties they are undergoing. So this makes the assessments a bit difficult. Coming to the physical settings, can we do something to make this children more comfortable while we see them? For that, there are few suggestions. One thing is, if we are working independently, or ideally the situation should be like the consultation rooms or the premises of the child psychiatry OP should be child friendly, in the sense, ideally the walls and the other areas should be painted with bright colors, with stickers of cartoon characters all around. And I don't know how many of our institutes have such a very child friendly atmosphere. So if we cannot change the institute premises, we should take care to change our consultation rooms. For example, if you're a person in your second year of MPhil training and you are sure that you are posted in child and adolescent psychiatry, or if you are given a child and adolescent posting, the first thing you should keep in mind is, it's my responsibility to make every child who's coming to see me comfortable at first hand. So for that, what we can do is, you can equip yourself with certain things which the child can be made very comfortable. Like you can carry some soft toys, some papers, color pencils, crayons, balloons, stickers, and chocolates if possible. So if you have all these things in your hand, while the initial intake, when you are asking details to the child, or when you are trying to build a rapport with the child, if you can give a sticker to them, or if you can just give a crayon to them, it will make them much more comfortable with you. And I have experienced that people will be coming, parents will be coming, and while we are observing the child in the clinical setting, most of the parents will keep telling the child that you should sit quiet, otherwise this doctor is going to inject you, which is never our intention. So child is, otherwise also the child is afraid of the setting, and when the parents are telling that these people will inject you if you don't obey them, if you don't sit quietly, they are going to put you here, and they will ask us, is that true, doctor? Like, we are going to put you inside if you are not cooperating for the evaluation. That is again another very difficult situation. So if you have certain skills, like you have a smiling face, you try to attract the child with the way you communicate, with open gestures, with your facial expressions being very friendly, it is easy to establish rapport with the child. And to make the child comfortable, you can give them certain tasks. Like you can give them crayons, you can ask them to draw a picture for you, or you can ask them to write something. And while the child is busy writing or doing certain things, you can observe how they are progressing. And when you meet the child, always make sure that you have gone through the available documents, because most of the institutes will have a hierarchy or a structure wherein most of the children are screened by the medical officers and then sent to PSW consultations. The PSW consultant may see the child in brief in the beginning, and then the case will be allotted to the MPhil trainees. So by the time the child reaches you, you will have some materials which you can actually go through or read, and then only you start seeing the child. Because when you do directly see the child, it will be very difficult for you as a student to assess what the actual problem is. So it is always better if the child have a document, or the parent is giving you a document, take it, read it, then only start seeing the child. And always keep in mind that you should be seeing the child first. If the child is above 6 years of age, it is mandatory that you first see the child, and then only you will be seeing the parents. Parents will come and request, or they will demand that I have lots of things to tell you. Let the child sit outside. I'll tell you first, and then you call the child. Then it should be uh, told to them in a very clear manner that we have a protocol wherein We will be seeing the child first, and then you will be given time to discuss about your concerns or your worries. Otherwise, what happens if you are seeing the parent first, or if you are giving the parent the first slot and talking to them, the child very well knows that now the therapist is not going to believe in whatever I'm saying. They are already prejudiced, and the parents have told all bad things about me to the therapist. So they are not going to trust me. So, in order to avoid that, it is always better to see the child first and talk to the child first and tell the parents that they will be given an opportunity to talk. But with children who are below 5 years, it is very difficult, and never try to force them to sit alone with you. If initial phase, you can make the parents sit alone and just try initiating a conversation with the child. By that time, the parents may start telling things. Then you ask them, you can keep quiet. I'll give you a chance. I'm just observing the child, or I'm just seeing what is happening in the consultation room. Then the parents will be able to follow your instructions and they will sit quiet. And if you feel that the child is comfortable with you, you can ask the child, can I send the parents for 5 minutes? Can they sit outside while we talk to each other? Then if the child is agreeing, appreciate the child for the decision, and then ask the parents to sit outside. If the child is very worried and clinging to the parents, never ever force the parents to go outside the room. Let them sit there. And always start with neutral topics. Like, you can ask the child, what is your actual name? Maybe the child will say some name, and they will have obviously a pet name which is being called in the home. So you can ask them, what is your pet name and what name you want me to call you. Some children say that you can call me my official name, my parents only will call me my pet name. If the child allows you to call their pet name, you make a note of it in the case file across his biological or original name, and then put the pet name in the brackets, so that in the next follow-up, the other person, if you are not the student who's in charge of the case, the next person also will have it as a tool to establish rapport. And children likes to be called in their pet names at times. And you can ask, if you have read in the documents that the child is having school refusal or issues in the school, better not to ask questions, neutral questions related to the school. Other than that, you can ask them what are their hobbies, what are their areas of interest, what they would like to do out of the school hours, or who is their favorite cartoon character, who is their favorite hero, and ask them to talk about. And if the child is a fan of football or cricket, it's better if you know few of the players and few of the matches which have recently happened, and then start discussing about all those things. And listen to the child's version why he or she is here. Like, after initial conversations, if you feel that the rapport is good with the child, then you ask, what made you to come here? Then listen to the child's version of the problem. They may say that I have difficulties in controlling my anger. They say that my parents complain that I am going backwards in my academics. Or some children will always also say that I'm very disobedient at home. That's why I'm here. So they are actually very, very open in discussing their concerns. And it is always better to trust the child's version. Children usually may not cook up stories. So you can actually believe the version of the child, make a note of it, and then you call the parents for discussion. Coming to gathering information in child and adolescent psychiatry, it is always better to gather information from multiple sources, like parents, the siblings of the child, if they are elder and able to give you information, grandparents, and other relatives who have accompanied the child. In most of the families, especially in Kerala, both the parents are working and the children are in the custody of the grandparents. So if parents are the primary informants, while they are giving informations, you can make out that they actually don't know what is happening in their absence at home. And if you feel that maternal aunt or grandparent or paternal aunt is the person who's spending time with the child, it is always better to ask them to come for a follow-up, so that you can have much more information in hand. So it could be parents, it could be siblings, it could be grandparents or relatives. Collect information from all the possible sources. Then it is important to collect information from the school, especially from the friends of the child and from teachers. And if they are going to kindergarten and other places, there will be some helpers or ayas in the kindergarten. So if possible, you can collect information. For that, you need not go to the school. You can just ask the parents, is it possible for them to get a school report for the next follow-up? Then collect informations from the social situations, friends or neighbors, and referral sources. If the child is being referred from a child welfare committee, it is always good to ask for their version of the problem. And nowadays it is very, very important that you collect information from the social media account of the child, because nowadays adolescents have a tendency to put their emotions on social medias. If you have access to their Instagram pages, or if you have access to their profiles, it is very evident that whatever emotions are they are undergoing, they are very open and ready to put it in the social media sites. And you should keep in mind that you are not supposed to break confidentiality. You are not supposed to intrude in the personal domain of the child. But if the parents are saying that the child had recently put a status which shows that the child is in support to the suicides which has happened in their locality, so these kind of informations are very, very crucial in the current scenario. Then other thing which we need to do is observe the child whenever possible. It could be outside the consultation room, it could be inside the ward in an IP care, or it could be in the play area, because that is an unstructured time where you can see the child in their own natural emotions or natural ways of play and interaction. So in during that hours, if it is possible, check for their activity levels, like whether the child is active, playful, is the child socializing with other children in the play area, what is their attention span, are they able to attend to certain things, or are they running around very distractible, and what is their ability to tolerate frustration, like mother is asking the child to give the cell phone back and you see that the child is crying aloud sitting outside your consultation room. So these are indications that what is this emotional responses to a frustrating situation. And you can also check for the creativity of the child. If you are giving the child a task to complete as you are talking to the parents of the child, then you can also assess how creative the child is. What are the objectives for detailed evaluation in child and adolescent psychiatry? The main objectives are to find out if there are any serious medical issues or organicity in the particular client, to assess the temperamental history of the child, to assess developmental issues, to assess the environmental background of the child, look for protective factors. Like if a child is having a problem, what are the protective factors which is actually considered as a strength in the family? Like child may be having a sibling who's willing to take care of him in the absence of the mother, or it could be like parents are very understanding, they are very supportive, they are spending quality time with the child. So these are actually the protective factors in the family. Then whether the child is having some vulnerability issues, like the child is having delays in their development and not able to control the emotions. So these are vulnerability factors. Then you should also get informations about the interests of the child, the hobbies of the child, the talents they have, past treatment details and the responses of the child to those treatments, and to arrive at a diagnosis and to plan and management. These are the general objectives of assessment in child and adolescent psychiatry. We have 15 steps in detailed evaluation in child and adolescent psychiatry. Some of these are very similar to that of adult psychiatry workups. So I'm not going to repeat all those things, but certain areas which are different, we will discuss about. The 15 steps in detailed evaluation is, first is the socio-demographic details of the child, as we do in adult psychiatry. Then comes the chief complaints. Then Actually, it is better to collect family history in case of child and adolescent. Then we will move on to personal history, then temperamental history, medical history, past history, history of presenting illness, negative history, general physical examination, mental status examination, task given to the child, summary of the case, formulation, and the diagnosis plan. Most of these things will be familiar terms for you, but there are certain areas which we need to have a look on. So coming to the demographic details, we usually collect information from all possible sources, as we have already mentioned. There we will be collecting information like name, relationship, and since when the name, then it's the name of the child, age, gender, schooling, occupation, and socio-economic status. So gender, coming to the schooling, it is like since when the child is on to school, what are the areas of the schooling history, which we will be discussing later. Coming to the occupational status, you may be wondering why occupation is being put under the step of detailed evaluation in demographic details for a child. Most of the children in certain low income families do go for jobs, especially the adolescents. They do part-time jobs to earn for their livelihood. So we need to ask the child if they are having other responsibilities. Are they occupied somewhere else? Are they gaining some income through some of their hobbies? So it is always better to ask all those things and ask for the socio-economic status of the child. Then you should collect the details of the informant, as in adult psychiatry. Who are the informants? What is their relationship with the child? How long they know the child, or how long they are staying with the child? What is the reliability of the information and adequacy of the information? Reliability and adequacy, I hope you people know how to conclude that an information given is reliable and how to conclude that the information is adequate. Then coming to the chief complaints, it is always good to collect the chief complaints in the child's version and in the parent's version. It may be different in both the versions, but it may be common in both the versions too. And what are the chronological order of the complaints? What complaint was observed first, and then how it moved on, how long that complaint started, and what is the duration, that is the duration of the presenting complaint or the chief complaint, and what is the reason for consultation at present. In child and adolescent psychiatry, you may see a case or see a child at the age of 5 years presented with delays in their development. They have come for single consultation, and now you are seeing them at the age of 15 years, so that the child has and the family has missed follow-ups for almost 10 years. So what is the reason for consultation at present? That is a very valid information for us. Maybe the special school or the school has asked the parents to take an evaluation because of some inappropriate behaviors that is of recent onset, or it could be because the family is in need of a disability certificate for which they have approached the treatment team now. Or if it could also be like the child's symptoms were under control all this time, but now it has become very difficult to manage the child. This is in the case of children who have taken an earlier consultation and missed their follow-ups. But with certain other children, they are coming to the consultation for the first time, but they have come now because of some disciplinary issues. The school have asked the parents that the child can be permitted into the school only if they produce a certificate from a mental health professional, or at least the child should be attending counseling sessions before joining the school. That may be because of some disciplinary issues. And then while working with children, we need to know the major domains of difficulties the child will have. We have three main domains in which the children will have difficulty. or the rather it can be said that the difficulties or disorders in children fall in three major categories. One is behavioral disorders, or which falls in behavioral domain, then emotional domain, and then developmental domain. Any mental health problem in any child can be fit into any one of these three domains. In the behavioral domain, as the name indicates, we know that the child will have problems related to the behavior. For example, it could be disobedience, where the child is not um, following instructions given by the parents. The child is back answering, have some oppositional defined symptoms, or having some disruptive behaviors, and the child is very difficult to manage. These are under the behavioral domains. And the second major domain is the emotional domain, where we generally classify the mood disorders like depression or manic episodes, and then the anxiety disorders, then adjustmental disorders. Everything comes under the emotional domain. Then we have the developmental domain, which is mental retardation, specific learning disorders or disabilities, and illnesses like cerebral palsy, autism spectrum disorders, and so on. So all the illnesses will fit into any one of these domains. Then we will be slowly moving on to the family history of the child. This is again slightly different from adult trauma. After chief complaints, we need to know the family background on which these problems are existing, where we will be asking about the family issues. Are the family having a very strong bond between each other? Hope you people might have got informations about the assessment performers which we follow for our case records. In that, if you remember, we have almost all these domains being covered. So if there are any issues between the parents, we need to make a mention of those in the family history. And what is the attachment pattern of the child? Are there any issues with attachment? Because some children are very clinging to their maternal figures. They won't allow the mother to move away from them. They are very cranky when they are separated from their mothers. Like that, if there are any attachment issues, or it could be the other ways, the child is not at all comfortable with the father figure. Whenever the father is around, the child starts crying, child has difficulties. So these kind of problems usually come under the attachment issues. Then what is the environment of the family? How comfortable the family as a whole unit is. And during this phase, we are actually trying to establish a rapport with the family. Initial intake, we will be seeing the child at first and establishing a rapport with the child. And then during this phase, it is easy to establish a rapport with the family, where you will be asking questions to the parents about the family background. Then obviously we will have to follow the 3 generational genogram, which we do in adult psychiatry. There we will be asking for family history of any medical or psychiatric disorders, especially disorders like family history of mental retardation, family history of autism spectrum disorders, family history of delayed speech, learning disability. All these informations are very crucial in child and adolescent mental health. Then are the parents consanguineously married? And what is the type of the family, like whether the child is belonging to a nuclear family, whether the child is in a joint family or an extended family. Because as the family type changes, the disciplining pattern and parenting styles may also vary, which is very difficult for us to make out after we finish the initial assessment. So it is mandatory that you keep it in mind that you will ask for the family type. How many members are staying together? Who are the people who are very lenient to the child? Who are those who are very strict to the child? Whom the child is afraid of? Whom the child is very much attached to? Who are the people who fulfills all the demands of the child? All these informations are very, very relevant for a mental health professional. Then we will be asking for the living arrangements of the family, like are they staying in their own home, or are they staying in a rented home? Is there a threat that the family or the child are going to be thrown out of the home? How is the environment, like how is the neighborhood? Are they in conflict with the neighbors? Is there any threat to the child or the integrity of the family. Then what is the parent-child relationship? What is the sibling-child relationship? And what are the child rearing practices which are followed by the family? Then, as the adult psychiatry psychosocial assessment pro forma indicates, what is the leadership pattern in the family? Who is the breadwinner? Who's the major person who takes decisions in the family? Is that an autocratic or a democratic way of decision making? All these things we need to know about. Then, what is the communication pattern in the family? Like, is there a switchboard communication which is existing there, or are the children asked for their opinions? Are they able to share their feelings? Are they able to share their emotions? And are they being attended to? Then, is there any stressors in the family? And is there a history of discord between the parents or grandparents? And another very major important thing which we don't ask in adult psychiatry and which is very relevant in child and adolescent mental health is asking for the typical day in the family. Typical day means what happens in the family from the time the child is getting up from sleep and till the time the child is going back to sleep. So that is the typical day for the child. So what happens? After asking that question, you can just wait for the response. Don't interfere in between. And if you feel that the family is stuck at a point, you can ask leading questions like, okay, what time the child gets up? You can just put a general statement that I need information about the child's typical day, like from the time he's awake till the time he's going to sleep in the night. So the parent will start telling that, okay, the child will get up by around 6:30. Okay, then you'll have to ask then, we will feed the child or make the child sit in front of the TV. Then he will demand for food. We will give that. And then he will be playing. So this is a time where we can make out how the parent-child interactions are happening in the family. For example, in cases of children with who are at risk of autism spectrum disorders, when we ask for this typical day, it is very evident that the child is not attended during the daytime. Not attended in the sense their physical needs are being met, but they are not in the they are in the physical presences of other family members like grandparents or parents, but the child is in his own world. Grandparents and family are in their own world. They are busy doing things. And when you ask them, they will say that the child is playing. Okay, fine. What are you doing at that time? Then you will be able to make out that there is no interactive play. There is no one to talk to the child or no one to play with the child. So these are indications which give us a picture of what is happening in the family atmosphere. So never miss to ask about the typical day of the child. Then moving on to the personal history of the child, they will be seeing about the birth and early development. Then prenatal history, like a mother's physical health during a pregnancy, whether she was having any difficulties, was she on any medications, was she infected with some illnesses, was she having malnutritious status? All these things comes under prenatal history. Then perinatal is immediately after the child's birth, whether birth cry was present, what was the birth weight, and after that, whether the milestones of the child was age appropriate. So milestones and impression about the milestones will help us to fit the child into whether the child is having a developmental kind of issue or something else. A child with the developmental problems will always have difficulties in attaining age appropriate milestones. In milestones, we will be collecting information from 4 domains, like what are the motor milestones, what time they have attained that, then cognitive milestones, social milestone, and language milestones. In motor milestones, as most of us know, it will be like head holding, rolling over, then sitting with support, sitting without support, standing with support, standing without support, walking with support, without support, all those kind of child is able to skip. All that things will be under motor milestone. Cognitive milestones is basically like whether the child is able to track objects which are moved in the line of vision. Are they able to understand things? Are they able to extend their hands to decide object? Are they able to grasp things? What about their pincer grasp capacities? All this comes under cognitive domain. And in social domain, whether the child is having social smile, whether the child is trying to imitate others, whether the child is able to establish a communication pattern with at least their parents. Then language, like crying, cooing, babbling, single word communications, pointing, then all these things comes under language milestone. Then we will have to make a comment on whether these are age appropriate or are they delayed. And also check for the self-help skills of the child. Especially the children with developmental disabilities will have difficulties in their self-help skills. In self-help skills, we need to look about brushing, bathing, eating, dressing, and toileting skills of the child. Whether the child is able to do it on his own, if it is age appropriate, or if not, who's doing things for the child? Is it because the child is not capable of doing that, or is it because the child is not trained in doing self-help skills, or is it because the child is not cooperative to train self-help skills? Then about the schooling history of the child, like age of schooling, whether the child had any difficulties in academics, what is the stream of the school, whether it is a mixed school, or whether it is a residential school, or whether it is a boys only or girls only school. Then change of school, whether the child had to change his favorite school because of some external reasons like transfer of their parents or relocation of the family, and what was the child's level of adaptation to those kind of changes. Then what are the parental expectations about the child, what are the teachers' impression about the child's academic activities, and whether the child had any negative experiences in the school context. So all these informations will be under schooling history. Then we need to ask for menstrual history and sexual history. Don't ask all these questions to children who are of younger age. If the child has attained puberty, or if the child is in adolescent period, then only you ask for the menstrual and sexual history. Otherwise, you can skip this. And ask for opportunity for sex education, like have any of the family members or any school authorities told them about what is going to happen in their physical development, how to respond to that, if menarche has started, what to do, how to keep personal hygiene, all these things can be asked. Then if the child is having, you need to check whether the child is having any body image concerns. As most of us know, adolescence is a period where the growth spurt is very prominent. So that most of the children may not have a very comfortable stage of accepting all these changes. So you check for any body image concerns of the child, age at menarche, when was the last menstrual period, and reaction of the child to menstrual cycle beginning. Then moving on to the temperament of the child. Temperament is actually patterns of emotional and behavioral reactivity to environmental situations and the capacity of the child for self-regulation. This is actually what is meant by temperament. There you will be asking for attention and concentration of the child. What is the activity level of the child? How the child is adapting to environmental changes. What is the impulsivity of the child? Rhythmicity in the sense regularity and predictability of biological functions like sleep and appetite. Then intensity of reactions, like how the child reacts to an emotional situation. What is the threshold of responsiveness? That is to make the child respond, how significant should be the threshold, like how frequently or how powerfully you need to ask something to get a response from the child. Then quality of mood of the child, then activity level, attention span, social relations, sensitivity, and then general mood of the child. Then we will have to collect information about the attachment patterns of the child. Then we will move on to the past history. So after temperamental history only, we will be having past history in the case of child and adolescent assessment. Past history is just as we do the past history in adult psychiatry. Then history of presenting illness, again same with the adult psychiatry pro forma, negative history. Then general physical examination, mental status examination, These are almost similar to that of the adult psychiatry performer. Then we will have a task given to the child. Usually, I have in the initial slides itself, I have told that it is always better to have pen, paper, color books, and other things with you. So these are actually useful while assessing the child. Like you can ask the child to write down something. If the parents are telling or the information is leading to the child having learning disability, you can have a writing sample from the child. You can ask the child to write, or intellectual functioning also can be assessed by giving the task like addition, age appropriate multiplication, subtraction, then dictation kind of thing. You can ask the child to write down certain words, or you can actually give a local language book and ask the child to copy it if it is age appropriate, to find out whether the child is having any difficulties. So if you feel that the child is having difficulties in cognitive functions, like if you suspect intellectual disability in the child, and because of the parental version and IQ appointment is not yet done, it is better to have few tasks given to the child so that we can actually talk to the parents to reduce their expectations about the academic performance of the child. For example, you can ask them, if you have coins or currencies in your pocket or in your purse, you can just give them and ask them, like, are they able to recognize the currency, like if it is a 10 rupee or is it a 50 rupees. And you can give questions like, if I give you 50 rupees and I ask you to buy things for 20 rupees, how much money will be remaining. All these kind of questions can be asked to children to make out, or these are the tasks which we actually give to the child. And for certain children with children having difficulties in verbalizing their problems, we can give them paper and pen to either write it down or they can actually draw. I have seen children who are having abuse history drawing beautiful pictures, beautiful in the sense making it very clear that what has actually happened to the child or what are the emotional traumas they are undergoing can be depicted through their drawings. Don't ever force the child to follow an activity, rather give them a chance and give them a opportunity if they want to express themselves with some other activities. Then another important thing is to ask for the 3-wish. You may be knowing this 3-wish test is actually a projective test to find out what is the emotional status of the child. Have you heard of this 3-wish test? Any of you? Okay. In the 3-wish test, we will be asking questions like, we are giving them a situation, and you can actually ask the child, do you believe in God? Or have you heard of some superior power which is above us, which few people call as God or few people call as destiny? Do you believe in that? If the child says yes, then or if the child is saying no, you can ask other situation, like you might have read in stories that goddess will appear if you pray hard and then fulfill your wishes. Most of the children will agree, yeah, I have heard. Then you are giving them an arbitrary situation and telling them that, see, now I'm giving you a situation where the god is going to appear in front of you. You can ask 3 questions or 3 wishes to the god, which will be granted immediately. You will get only few minutes to ask the question. So now your time starts now. This is actually a projective test. Most of the children, when given such a situation, will be coming up with their internal worries. I have seen children telling that my parents should stop quarreling. I should be able to pass my exams. I should be having enough money to pay rent so that we have peace of mind while staying at our rented home. So these are actually immediate responses. Don't give them long time to think. It should be their immediate reaction to the question. So this is a way for us to understand what is the actual trauma the child is having. Then it is like summarizing things. Then formulation, like scientifically putting down whatever informations you have gathered from the child, the other sources and the family, and then planning the management, rehabilitation, and psychosocial interventions. Usually the diagnosis is multi-axial in child and adolescent psychiatry, where in axis 1 we will have the psychiatric disorder the child is having, axis 2 will have developmental disorders, Axis 3, intellectual functioning. Axis 4, medical problems of the child. And axis 5, the psychosocial issues the child is having. So we are looking at a biopsychosocial perspective, taking into account the inextricability of interlinked aspects. So the biopsychosocial model, if we follow, it is very easy to understand the child or the situation or the parent from a totality. Then only you will be able to make out the management plans, and then only the plans will be effective while working with children. Clinical history taking and interviewing are one of the most powerful tools available in the absence of laboratory investigations to the child and adolescent mental health professional to make a diagnosis and a plan. While doing assessments in child and adolescent psychiatry, you should keep in mind that confidentiality and the limits thereof must be discussed with the child and family. Documentation is yet another thing which most of the psychiatric social workers are very behind in doing, but which is very, very important aspect of assessment and which should actually be strictly maintained. And then a comprehensive clinical assessment goes on a long way in ensuring interventions in the best interest of the child and family. And moving on to the psychosocial interventions, from a psychiatric social work perspective, the first and foremost thing is the collation of information like detailed case history. Then in child and adolescent psychiatry, it is very, very important to deal with the difficulties which the parents are facing. If either the child is having a developmental problem or a behavioral problem or an emotional problem, as we have discussed earlier. So all parents will have lots of expectations about their children even before they are born. So it will be very, very difficult for the parent to accept the fact that their child is having a disability, especially in the case of developmental disorders. So it is the role of the psychiatric social worker in the unit to attend to the psychosocial needs of parents of children having difficulties. So you may have to be the person who's going to break the bad news. You may be the one who's going to help the parents how to train the child with special needs, or you may be taking the role of identifying the resources available near to the child, or planning the rehabilitation opportunities the child should be sent into or child is in need of. Then at times the psychiatric social work interventions will include family therapy, marital therapy, parent management training, cognitive behavior therapy, and the rehabilitation aspects. So the psychiatric social worker working in child and adolescent psychiatry should be equipped to do all these interventions. Mostly you may not be able to refer the child for behavioral therapy to other unit and you doing the parent management training. It is always better you combine both, otherwise it will be having parents may get confused. If the psychologist is doing the behavioral therapy and you are going to do the parent management training, it is either going to be the replication of the other, or it could be like you both are talking two different things to the same parents. So always make it a point that you see the child, you see the family, and then you plan the intervention, and with the support of your clinical supervisors, implement the intervention plan and take the feedback. And other than working with the parents, you may be having time to work with the children directly, providing them support, or training them in their activities of daily living, planning their schedule, and also working with the schools. At times, schools will have some misconceptions about the child. Then you will have to visit the school, make things clear. And if the child is having a school refusal kind of problem, you may have to plan a graded exposure to the school. And if the child is being bullied at school, you may have to conduct a school mental health program. So the role of a PSW is very divergent in child and adolescent mental health, but it is actually very, very interesting. In my 10 years of experience, this is something which I really enjoy. Compared to the adult psychiatry unit, wherein you will be seeing patients who are very chronically ill, with interventions, it is very difficult to make them have a 100% normal life. And somehow it will have some kind of negative impressions on our capabilities, our own self-esteem. But working with child and adolescent mental health, you will actually feel very happy when the parents are coming in the next follow-up and telling that my child is having a significant improvement in their behavior. So actually it is very, very enriching. In my version, it is very enriching and very nice to work in child and adolescent mental health psychiatry. Thank you all the participants for your patient listening. Have a great day. Good night.